everybody, and welcome back. This is Bolus Videos, and today our videos are actually sponsored by a great sponsor, EM Transport and Squad 81. I'd like to thank them for their sponsorship today. Today we're going over trauma, and trauma has a lot to do with common sense. Common sense being that this stuff is relatively simple and easy if you could just focus on what needs to be done. So today's topic is one of my big favorites, especially in trauma: hemorrhage control. Hemorrhage control is a big thing in PH-TLS and ATLS. It's why we call it CAB instead of ABC. Now here's the thing. Trauma equals naked. Out in the field, you cut clothes off, you see stuff you don't want to, but we be mature about it, and we try to keep their privacy as much as possible. But the fact of the matter is you're going to see genitalia. That includes vaginas, wieners, well, not erect wieners, we'll say, flaccid wieners. You probably won't be seeing anybody with erection except if they have a spinal injury, but you also see boobs and butts. But I need you guys to get over it. It's okay. We're human. It's going to happen. So, moving on. I'm going to draw out some of our, more commonly used pads. So we have the 5x9, the 12x30, my favorite, the 4x4, and we also have the occlusive dressing, and one more that I like to use, the Tegaderm. And we'll see how that actually plays out in some of the scenarios we have in class. But the big thing about stopping hemorrhage is DP. But DP actually means direct pressure, not the other things, you dirty-minded students. You sick people. DP is the best thing. Direct pressure. That's what we use to stop bleeding. That should be your first line defense. Now, let's take a scenario. You are currently trying to stop a femoral bleed. You pick one of these big trauma dressings and you apply pressure, and all it's showing is that dot right there. Well, what you don't know is that most of that blood is actually still being soaked up by that, but not showing through. Those big trauma dressings don't like to show stuff. And when they do, there's a lot of blood that's already been soaked up into the bandage itself. That thing basically acts just like a sponge. Here's what I'd rather you do. Get a 4x4, a 5x9, something small, something not as dense. Put 2 fingers and apply direct, hard pressure to it. Yeah, it's going to hurt. It's going to hurt the patient. You're going to have gloves on. You might get a little dirty, but it's going to stop the bleeding better than a large trauma dressing. Because when you apply those, you're putting a sponge on them. That's exactly what you're doing. You're just putting a sponge on them, letting that trauma dressing soak up all of that blood, and not letting them clot very well at all. Here's a good question. How long till I move on? I've been holding pressure for a while, and I want to know when this stuff is going to stop bleeding. Well, we normally clot at a rate of maybe 25 to 30 seconds. But there are a lot of stuff that can elongate that. There can be pathologies, medications. I mean, heck, even if you're too cold, your whole clotting cascade gets put on the back burner. So a lot of things can affect how long it takes for you to clot. The main thing is that holding pressure is good, and you're going to hold pressure even if it's on the whole way to the hospital. You did a great job. The bleeding stops. Let's pretend that it stops. You know what I mean? You don't have to hold it all the way to the hospital. Let's go over some stuff. Let's go over bandaging. And up first on the list is the Israeli bandage. Next, we're going to talk about some Coban and all of its fancy colors. We got Curlix on every rig. Everybody knows a lot about that. And the SWAT bandage, something that I really like. It's a little new, and I like it. But let's first talk about the Israeli bandage. So this Israeli bandage, it actually has those 2 prongs at the top. When you wrap around them, they act as a pressure dressing. Now, a lot of us have had to do that DIY in the field, but this one actually comes with it. That's one of the reasons I really do like that Israeli bandage. The next one is Coban. Coban comes in a whole bunch of fancy colors. It sticks to itself, and it's relatively cheap. I have some myself, and I use it whenever I need to make a dressing that's already clotted off. Curlix is a common tool in our toolbox. We use it almost every day, and for good reason. It shows blood, and it's great use in bandaging. it also makes DIY tourniquets, so it's a great product for EMS. The next one, not so commonly used in EMS, it's the SWAT tourniquet. It sticks to itself, it's hydrophobic, so that means it really doesn't show blood that well just because of the texture that it's made out of, but they do use it a lot in tactical situations, mainly because it's self-adherent and you could put it on yourself if you need to. We don't really see a lot of these in EMS, but I'm sure they'll get there one day. The last one is ACE wraps. And I'll be honest, ACE wraps have been around for a while, and for good reason. They're easy to use. You could buy them at Walgreens, and they're basically the inbred baby of Coban and Kerlix. That's how I like to look at them. But moving on, let's go to another topic. Let's talk about occlusive dressings. And there are a lot of variations on occlusive dressings. We got saran wrap, Tagaderms. We can even use the backing from, normal packaging and tape. Or we have normal Tagaderms, and we have chest wall bandaging. Let's talk saran wrap. So, not really used on ambulances nowadays, but it used to be used a lot back in the day, and for good reason. It's hydrophobic, it shows blood, and it keeps stuff from coming in and out of the barrier that it's placed on. Let's take an example. You're dispatched to somebody with abdominal pain, right? You get on scene, you lift up his shirt, and then, oh my God, what just happened? He has an evisceration. Gee, somebody stabbed him. So he has his organs popping out and all this is happening. What do you want to do? You want to make sure those organs are wet. You don't pull them in or out. And you want to wrap some saran wrap around them. Wet gauze and saran wrap will keep anything from coming out and going in, and also keeping those organs moist. That's what we want. We don't want to add any more things in there or take anything out. All right, you fixed Mr. Abdominal Pain. Great job. Let's go on to some other things that you could do with these occlusive dressings that are actually pretty cool. The next one is a Tagaderm. Yeah, we use it for IVs, but you could use it for some other stuff too, especially in wound care. Take this for example. You have a guy who has an injury to his neck. Say he got stabbed in his neck, stabbed in his upper clavicle. One of the things we want to worry about is air getting into those wounds and causing air embolisms. What we can do is, along with direct pressure, apply a Tagaderm and not allow any air to enter and blood to exit that wound. It'll make it a lot safer for the patient and reduce the risk of air embolisms. Let's check out my last 3 examples for occlusive dressings. Oh, went a little blurry there. I think it just might be your eyes. Anyways, we got a guy who's shot in the chest, to the right of the mediastinum, mid-clavicular. What do you guys want to do? What are you guys thinking? Chest seals. Exactly. This one is a Bolus chest seal. It's made specifically for these. They want to prevent a tension pneumothorax, and you don't have to be a paramedic to use these. Here's a little easier representation, and some that most departments have. This is called a chest seal. So it allows air to exit, but doesn't allow air to come back in. And the reason for that is we don't want a buildup of pressure within inside our thorax. So you place this right over the wound, and as we breathe, it allows air to escape, preventing a tension pneumothorax. But there's a DIY way we could do it too. You know how they say put a 3-sided, tape it on 3 sides, 3-sided dressing for an occlusive dressing? Well, you could do it on 4. The basic thing is that you burp it every chance you get. Because if we don't burp it, we get that increase in pressure within inside our thorax and we get a tension pneumo. That's the reason it's 3-sided or 4-sided. Don't forget to burp it. Moving on from chest seals and all those occlusive dressings, let's check out something that we normally don't get to see a lot in EMS. It's quick clot and Celiox. Now, these are powders and impregnated gauze with these special powders that are supposed to allow you to clot quicker. We don't really use them a lot in EMS, but there are a lot of use in the military, and soon it will be coming to us. So we'll probably do a video on that later. Now, on to the final and one of the most important topics, tourniquets. There are a couple different types. There's the CAT tourniquet, the combat application tourniquet, widely used in the military and now applicable in EMS and almost on every ambulance. And then there is the single and double bladder tourniquet. These are more commonly used in ORs and operating rooms. Not really seen much in EMS unless you're trying to use it with let's say, a blood pressure cuff, and we don't really do that. It's something that we don't really like to do. Last one is the DIY. Make it yourself at a Curlex, whatever you can find. We don't use these that much in EMS either unless you are unable to get your hands on proper tourniquets. And to be honest, there's sort of an art to making DIY tourniquets. My favorite, though, are the cat tourniquets. I've used them on 2 patients so far, and they've been excellent. I haven't had that much use with the single or double bladders, and I have had to make some DIYs. They help in a pinch, but aren't the best solution. The main thing I want you to take from this is that do not be afraid of tourniquets. If you need to use them, use them. If someone has a really, really bad arterial bleed or bleeding that you can't stop with direct pressure, break it out and put it on them. It can be on there for longer than you're going to have the patient. Yes, it's going to hurt. Yes, you might need to give them pain medication, but it's going to stop the bleeding, and that's what's going to save their life. Arterial bleeding unable to be stopped, partial amputations, full amputations, use the tourniquets. Don't be afraid of them. You won't get cited for it. You need to save this patient's life, and that's the way that you're going to do it. So remember, direct pressure, bandaging, and tourniquets. We're going to be using those in lab. And the main thing to take away from all this is that it's common sense. If you guys have any questions about what we went over today, feel free to email me. And don't be afraid to ask questions. Remember, the most important thing about EMS is asking why. So feel free to ask me. You can reach me at emtransportradio@yahoo.com. And remember, no matter what happens, every patient is family. And we'll see you on the next one.